honored guest for today's lecture, and that is Electra Paskett, PhD from the Ohio State University Comprehensive Cancer Center, the James. And she's going to give a talk today entitled "A Multi-Level Model to Address Cervical Cancer Disparities in Appalachia." So in the field of public health as it relates to cancer, cervical cancer we now recognize is one of the biggest success stories because we now have the ability to vaccinate to prevent cervical cancer. And I don't think one can emphasize strongly enough what a game-changing event that was. However, there are still many folks with cervical cancer, many women with cervical cancer, and there's variations in the vaccine rate that has to be dealt with as well. So it still has a tremendous amount of policy issues around how best to prevent and treat cervical cancer. And so the story we're going to hear today pertains to issues as it relates to Appalachia. Dr. Paskett is currently professor and director of the Division of Cancer Prevention and Control at the Ohio State Comprehensive Cancer Center. She's extremely well published in the field. Her work is interventional research directed at cancer prevention, early detection, and survivorship issues. She's well funded, and in particular has an NCI-funded P50 grant to examine the rates of cervical cancer and why they're so high in Appalachia in Ohio, and that's the work we're going to hear about today. She's influential in the field, having been the past president of the American Society of Preventative Oncology, deputy director of cancer epidemiology, biomarkers, and prevention, and is the current section editor for the journal Cancer. In 2016, she became a member of the National Cancer Institute National Cancer Advisory Board, the most influential position an independent investigator can have in advising the NCI. And finally, she's been the recipient of fantastic and numerous awards, including the American Society of Prevention Oncology Distinguished Achievement Award, the Alliance for Clinical Trials in Oncology Jimmy Holland Award, an AACR Distinguished Lecturer Award on the Science of Cancer and Health Disparities, and an AACR Key Science Award. So, Electra, please join me at the podium, and we're delighted to have you here for your talk.
Thank you. Thank you very much for that lovely introduction, and it's really been a nice day and a half visiting with you all, and I've had a great time in my brief meetings, and I think we could go all day with each of you, and it's really been fun. So today I am going to tell you a story, and I think this is very applicative to the junior folks here. Because I'm going to tell you a story of a research trajectory that started earlier, but specifically here, 2002, and it all started with a picture. So when I moved to Ohio State University in January of 2002, and it was freezing cold in January like it is out here, and the National Cancer Institute had published this report of cervical cancer death rates in white women in the United States. And you can see over here, this is worse than a video game, right there, Ohio, red. Okay, so yes, we like our red for our Buckeyes, but red here is bad. These are the highest death rates in white women from cervical cancer. And you can see that's in the Appalachian area, West Virginia and Kentucky, but also, as rivals the death rates among the white women, mainly Hispanic women, along the Texas-Mexico border. So this picture really started a whole trajectory of work. So I'm going to tell you a little bit about Appalachia, because a lot of times when I go around, people have never heard of Appalachia. So Appalachia is a mountain defined by the Appalachian Mountain Range, which runs in 13 states depicted there. And Appalachia itself consists of 420 counties in those 13 states. It's divided up into 5 regions, color-coded there. And it was defined in 1965 by the then newly formed Appalachian Regional Commission because of the region's deficits, mainly in terms of poverty, lack of education, etc. There are about 25 million US residents that live in Appalachia, or 8% of the US population. Appalachia, many people think it's just rural, but no, it has some urban areas. So for example, Pittsburgh is in Appalachia, okay? I don't know how many of you knew that. Yeah, there's a story there, but we don't have time to get into that. So then it has both urban and rural areas, but it is less racially diverse than the rest of the United States, and it has higher poverty rates than the United States. And 78 counties in Appalachia are considered economically distressed by the federal government. There's also lower education in those counties. Traditionally, Appalachia is underserved in terms of the healthcare system. So we have excess mortality in Appalachia, with cancer and heart disease being the leading cause of death, but really cancer is the leading cause of death versus the rest of the US, where it's heart disease. And the factors that contribute to these health disparities include the lower socioeconomic status, which I've already mentioned, the lack of medical care facilities. I'll just give you a snippet. In the 32 county region in Ohio, that's Appalachia, we have 6 counties that have no mammography facility, no. And poor health behaviors and poor communication with healthcare providers, and I could add the poverty of the region. So one of our counties for 4 years had no grocery store in the entire county. So that's just a little snippet of what Appalachia is like. So we like you all, led by Dr. Warnecke, were successful in securing Center for Population Health and Health Disparities in 2003. And the tagline for this initiative was Cells to Society, Overcoming Health Disparities. And by this Cells to Society, we mean this model. And this is a model that Dick led the development of this manuscript, and it's lovingly referred to as the Warnecke Model. And it basically says that the reason we have health disparities, as you see on your right there, is not simply because of individual risk factors, but it's a mix of multi-level factors. And I love to give the example of tobacco. Okay, so we know that we see disparate health outcomes related to lung cancer. Okay, well, is it only because, let's say, African American men smoke? Well, no, it's not only because African American men smoke. Why do African American men smoke perhaps more? Well, let's look at it in this multi-level context. And we know that there are biological factors that make African Americans more likely to want to smoke menthol cigarettes. We also know that there is a biological factor for people to be more addictive to nicotine. And then let's move up to the social relationship level. Perhaps the African American men associate with family members and friends who smoke, which we know is less likely somebody will stop smoking, and that they live in an area where they have to walk home and they pass all of these corner stores that have huge ads about smoking, and they have people that look like them smoking a cigarette and enjoying life with a beautiful woman next to them, all right? And all of this, the things I'm telling you have been documented in the literature, so I'm not making this up. And then the institutions that perhaps they work at a place where it's easy to go out and get a smoke, or they go to a healthcare facility and their primary care provider, if they have one, never asks if they smoke. Never does the ask, advise, refer. And then they live in a state, and let's use my favorite, North Carolina or Kentucky, that has very low tobacco tax. Okay? So can you see how at all those factors, it puts it together for the person to keep smoking? And that's just one example of what we're talking about when we talk about multi-level factors. So there'll be a test on that later. So I hope you remember that model. Okay. So now I'm going to talk a little bit about our Center for Population Health and Health Disparities. So our goal has been mentioned already, was to understand why Appalachian Ohio women have high incidence and mortality rates for cervical cancer. So we called our study CARE, for Community Awareness, Resources, and Education. And initially we started doing a lot of qualitative work out in the community. We talked to women, community members, providers about cervical cancer, about the area, about the healthcare providers, etc. And very early on, we found that you cannot say the word cancer in community because cancer is thought to be a death sentence. And nobody wants to talk about cancer because all the people that they know who have been diagnosed with cancer were diagnosed at stage 4 and they died. Very similar in other minority communities, but in this underserved community, cancer was a death sentence. So we couldn't use the word cancer. And you do not talk about cervix because it's only those women who get cervical cancer. Okay? So full disclosure, okay, my mother, her first cancer was cervical cancer. She was not one of those women, right? So how do you research something that you can't use the word cervical cancer? First thing, you don't see cancer in our title of our study that was out to the public, or cervix. So we talk about community awareness, research, and education. And so this is the first 5 years. So when we submitted the grant in 2002, this is what we knew about cervical cancer. That risky behaviors like smoking, lack of Pap test behavior, and Hpv infection contributed to cervical cancer. So that's how we structured our study. And at the time we did this, there were 28 counties that were part of Appalachia, and we divided Appalachia, Ohio into those 4 regions, and then in each of the regions we took every urban county and we randomly selected 2 rural counties, so that we had 4 counties per region that we went to, and we enrolled clinics who did Pap tests on women. And that is how we got our samples for the study. So the first study was looking at a lay health advisor intervention to improve Pap smear. These are not navigators, these are community health workers or lay health advisors. And this is based on a lot of the work that I had done in Winston-Salem or North Carolina before I moved. So we had the women randomized to the intervention arm got 2 in-person visits by lay health advisors. And these women, we identified them from those clinics that we were enrolled, and the women all needed to have a Pap test. The women were also mailed materials on their stages of change in relation to wanting to get a Pap test, and then the lay health advisor followed up with phone calls. At the visit, what the lay health advisor did was assess the woman's individual risk for developing cervical cancer, address the barriers to receiving a Pap test, and provided educational material. The usual care arm, they were told they needed a Pap test, and they got a letter from their doctor and the NCI low literacy brochure about Pap tests. When we were in the program for 10 months, after which we did medical record review, as well as surveyed them again to use self-report to get uptake. So these are the results by medical record. However, when you work in an area like Appalachia, there was a lot of missing data from the medical records, and we didn't really believe this. And so you can see it looks like there's an effect of our intervention, but it's not statistically significant. And so we also reported in our final outcome paper self-report, which we also know is biased. So the truth is somewhere in between, but it looked like our intervention had an effect on increasing the proportion of women who got a Pap test. The next study was run by my colleague, Marianne Weavers, who focused on evaluating a lay health advisor, and we used the same lay health advisor in terms of staffing. And I should say that all of my staff come from Appalachia. So we wanted to use that intervention to see if we could get women who smoke to stop smoking. The Cessation Protocol included behavioral counseling, nicotine replacement therapy over 10 weeks. Usual care, or the control arm, got a letter from their doctor saying, hey, you should come and see me about smoking cessation. So this is the result, and you can see at 3 months and 6 months, there was statistically significant effect in the intervention arm in terms of cotinine-validated cessation rates, but at 12 months, we lost that effect. And Dr. Weaver is very interested in figuring out why, and I'll get into a little bit more about that. So the third study was directed by Mac Ruffin. At that time, he was at the University of Michigan, and just to change people's views, Ohio State and Michigan, we do get along for some things. And this was a study that Mac ran, and it actually was a case control study that was done in those clinics that I mentioned. And the goal of this was when women were coming in for pap tests, routine pap tests, they were already coming in, we consented them with our nurses who were our staff members, and we did extra swabs to be able to, one, type the prevalence of HPV. So this shows that the prevalence of HPV overall, as well as the high-risk types and the 4 types in Gardasil 4, were higher in our sample in Ohio Appalachia compared to the published data in non-Hispanic white population in the United States. And these are correlates, some correlates of infection with high-risk HPV type, and you can see younger age, current smokers, prior abnormal pap test, and increased risk with increasing number of lifetime and recent sexual partners. So what we found, this is really abbreviated here, I didn't go into some of the pilot work that we did, but in the background of the Appalachian culture, which I explained a little bit to you, we found a high rate of abnormal pap test, high rate of smoking prevalence. So Dr. Weaver has found that it's over 23% of the women currently smoke. And if you look at women with abnormal pap tests, about 68% of them were current smokers. We had high HPV rates, which I showed you. We already discussed poverty, risky sexual behaviors, and depression. So some of you might do work in cancer survivors. We've done work in cancer survivors. The depression rate on the CESD is probably in the high 20s. It was higher than that in this young population. And we also found less access to healthcare, which we've talked about. And in some of our qualitative work, we found that the women did not trust their provider. They told us things like, I don't know what he's doing down there when he's doing that exam on me, but I'm not sure he was doing a pap test. So there was a lot of mistrust amongst the population. So with those results, we submitted a competitive renewal for our center, and we were renewed for 5 more years. And we really built upon the findings that we discovered in the first 5 years. Plus, we had done a few pilot studies and found some interesting findings from the pilot work that we wanted to really flush out in full-scale study. So, we had published the model with Dick, and so we took the model, and it was really the basis for framing the second 5 years of our center. And so this again is the model. We just turned it 90 degrees, and we proposed in Project 1 to look at gene-environment interaction. Project 2 to look at social networks and social influence on smoking behavior. Project 3 to look at psychoneuroimmunology, looking at the effect of stress on the immune system. And Project 4. Project 4 was our multi-level intervention to increase the uptake of HPV vaccine in girls. At the time this was submitted, it was only approved for girls. So the first project was led by a molecular biologist. So in addition to multi-level work, we did transdisciplinary work. So I'm an epidemiologist, and I will attempt to explain the results of a genetic study. So don't anybody just wave your head or hands in disgust if I say things wrong. But Dr. Weghorst and his team were really interested in looking at inherited and somatic alterations of the Tgf-Beta ligand and receptor complex in cervical cancer. And he initially got this idea by looking at some some pilot samples from Dr. Ruffin's first project because he wanted to see the prevalence of the 6A allele in this population versus a population with cervical cancer in Kansas, and he found that there actually was a higher prevalence of this mutation. So he was very interested in looking at this. So he again wanted to look at the role of these acquired genetic alterations. And we know that Tgf-Beta receptor pathway, they are frequently altered in human cancers, whether they're somatic, deletions, insertions, or mutations, deregulation of gene and protein expression, and there are polymorphic variants in terms of SNPs. And again, he was interested in the 6A allele. So what he wanted to do, and this was designed as a case control study, was to examine the association between the various genotypes and cancer status, being a cervical cancer case versus a control. Now, first, cancer is a rare disease. All right, many of you might not think that, but from an epidemiologic perspective, cancer is a rare disease. Cervical cancer is an even rarer disease. Cervical cancer in Appalachia was really, really hard to recruit. Even though we have higher mortality rates, higher incidence rates, it was really hard to recruit. So we actually had to go to Kentucky and West Virginia. West Virginia is 100% Appalachian. So it took us a long time to try to find cervical cancer cases and then healthy controls. But from them, we were able to obtain blood, buccal swabs, HPV tests, and then we administered questionnaires to them. And they turned out to be, by design, the same surveys that we administered in Project 3 in the first round of CARE, so that we could use the healthy controls from CARE 1, where we already had blood and HPV and the questionnaire data in order to complete this study. So first of all, he looked at Tgf-Beta 1. It's a SNP in the promoter region, and he found an interaction of smoking status by genotype that was significant. And this was only in the homozygous women. Homozygous never smokers, it had a protective effect. So the odds ratio there is less than 1, indicating a significant protective effect. But then we looked at P53, which is in cervical cancer. He also found an interaction of smoking status by genotype, again statistically significant, but this time in the GG never smokers, and they had a higher risk for being a case, higher odds of being a case. So again, his question was, what is the prevalence of a genetic polymorphism in Appalachian population with cervical cancer versus control women? And the purple writing is what he was looking at, and what he found is there was some difference by tobacco use. And it begs the question, could this explain cervical cancer in non-smokers? Yeah. So this is what you're going to see now for the other 3 projects, but these boxes represent the boxes from the multi-level model. Now remember, I told you there's going to be a test, so there's going to be a test. So Project 2, Dr. Wierers directed, and from her study, remember I told you that effect kind of decreased by 12 months, there was no difference. And she also found, which was also reported by the Framingham study investigators, that smokers tended to have fewer people in their social networks. So we all have social networks, right? And if you think of a social network as a tree, right, there are branches and then leaves, right? Okay, so what Framingham found and what Dr. Wierers found in CARE 1 was that smokers tended to be way out there in the leaves with their few friends. And she said, oh, I wonder if it's social networks that influence smoking behavior. So I've already told you that smoking prevalence was high in the Ohio Appalachian women. Here we're at 32%. So the goal of this study was, let's look at social networks by smoking status. So are women who are never smokers more likely to have friends who are never smokers? And are women who are current smokers more likely to have friends who are current smokers? Because that will keep them smoking if all they associate with are smokers. And then perhaps if we find out that this is important, then we should do an intervention directed at the whole social network and not just at the one individual woman. So the first was to characterize social networks by smoking status. The second goal was to determine the association between all these multiple levels. So again, individual, interpersonal, workplace, community, and social networks to see what the effect is. So just to explain this, all of us ourselves are the egos. So you are the red circle, and your friends are the blue and the purple circles, right? And the lines between say, do your friends know each other? And that's how a social network is set up. So we did a cross-sectional survey in Appalachian counties. It was about an hour interview, and the respondents got a gift card. So these are who was in our study, about 400 women. Most of them had health insurance. You can see the age range. We got from 18 to 95. About 17% scored high on the depression screener, 20% current smokers, and 24% had a bachelor education, and you can see the median household income. So the next slide might be really hard for you to read because of how small it's going to look, but these are some of the results, and I just list up there the statistically significant effects, but I can tell you that what differentiated somebody being a current smoker versus a former smoker or a never smoker were things like age. So if the younger they were, the more likely they were to be a current smoker. Depression also was important, as was, so high, if you scored high on the depression score, you were less likely to be a current smoker. And then things at the interpersonal level, including social participation, the percent of ties in your advice network. So we have people in our networks that we get advice from, and then we have a network where we spend time with people. Some of us have two different groups of people, but both of them influenced if a person was a smoker. And then neighborhood cohesion. So at the neighborhood level, that was the factor that influenced whether or not somebody was a current smoker. So here are the boxes from the model for this project. And we looked at tobacco use, which is down there in the purple, and the things that influenced tobacco use were age, depression, social network, social influence, and social cohesion. So do we have the perfect storm for cervical cancer? We asked. We have tobacco use we know is a carcinogen. Genetics among non-smokers we saw. But what about infection with HPV? We know that's a necessary cause. But we had some idea that, is the vaccine going to work? We know that the uptake was lower in this population, but is it going to work? Because we found that this population reported that they felt stressed all the time. And these are the data I showed you before in terms of the prevalence of HPV. We know it's very prevalent. Is the vaccine going to work, though, in a stressed population? So that was what Dr. Ruffin looked at in the third project, which was HPV immunization response and stress. The question was, if these women are stressed, will they be able to mount an immune response once given the vaccine? So how are they stressed, and why is stress even important in mounting an immune response? So I've already explained a little bit about the background of Appalachia. So what we heard from the women is that they have low socioeconomic status and less access to health care. They also reported loneliness, and the doctors also reported that the women were lonely, so no social support. We looked at this factor called Appalachian Self-Identity. So many of you might know about the Hispanic paradox, and that is related to the social support that the Hispanic community gets from one another, and we thought maybe that might happen in the Appalachian culture. But my bright idea, we found that only about 30 some odd to 40% of people say they're Appalachian. So even though they live there, they don't identify as Appalachian. So they don't identify with a group, they're not going to get social support. And we found that the women had very bad coping strategies. So all of that leads to perceived stress. And what does stress do? It causes depressive symptoms. And how does one cope? You know, if they don't have coping skills, how do they cope? They drink and they smoke. And I can tell you in this young population, like the college age kids we interviewed for this project, you will see the binge drinking rate astronomically high, in my opinion. Okay. They also, on the other side, in addition to smoking and alcohol, the other risky behavior is sex. And we found that there were a high number of partners, early age of first intercourse, lack of condom use, and of course a history of prior abnormal paps. So you have this risky behavior along with the depressive symptoms, and the smoking and the drinking doesn't take care of the depression. And the perceived stress as well as depressive symptoms and the smoking and drinking cause immune dysregulation. And in order for the vaccine to work, you have to have a good immune system. So this was Dr. Ruffin's thought. So here, you know, the repeated sexual behavior increases the exposure to HPV. And even if you're given the Gardasil vaccine, can you mount an antibody change that will resist the persistence of HPV? Because persistence of HPV is what causes cervical cancer. So this was the model of stress and HPV infection that Dr. Ruffin was working on. So he recruited 185 women between the age of 18 and 26. And most of them were white because this is, as I showed you, very low minority group in Appalachia. And you can see self-identify as Appalachian, 39%. Never had sex, 4%. This is the mean number of sexual partners, 6.5. Look at the age, 23 years old, 6.5 mean numbers sexual partners. First age of intercourse, 16.6. 26% current smokers. Okay, 72% drink alcohol. 49% of the drinkers reported a binge drinking in the last month. And then CESD, 28% scored high on the CESD. So what did we find? Oh, I added this slide, sorry. So at baseline, we wanted to know how many already at this age were negative for cervical HPV DNA, and it was 50% were negative. So 50% already had some sort of positive cervical HPV DNA. There were only 11% for 16 or 18. So the question, does stress impact immune response to HPV vaccine? And we looked at this by looking at the impact on the HPV-18 titer change. So we measured HPV-18 at baseline, and then after a year, they got the vaccine, and then a year later we looked at the titer change. And we looked at it in relation to the perceived stress scale. And we found that a 10-unit increase in stress resulted in a 22% decrease in titer change, which means less immunogenicity. However, that was not a clinically significant difference. The impact on HPV-16 was only related to the number of lifetime sexual partners, where we saw a 60% higher titer change with greater than or equal to 4 sexual lifetime partners, and no other variables impacted the titers. So therefore, we can say that the HPV vaccine will have an effect on the immune system of Appalachian women, which was a big whew for us. So again, if we look at our boxes, what leads to protection against against cervical cancer, or not protection, but it's discrimination and perceived discrimination. Yes, these are all white women, but there is discrimination within Appalachia. And I can tell you a story, we have some time. Poverty, social cohesion, neighborhood disadvantage, social support, age and SES, and those are all related to depression and immune function. So the last project was Project 4, which we called the Parent Project. This was our multi-level intervention. So we were tasked with developing and then evaluating a multi-level intervention to increase the uptake of HPV vaccination rates among girls. And again, at this time, the vaccine was only approved for girls. So the levels of intervention were parents, healthcare providers, and then the healthcare department or the provider office. And we tested the intervention in 6 Ohio Appalachian counties that were intervention and 6 usual care Ohio counties control. And the communities do not like to get nothing. as usual care. So we designed a parallel intervention focused on the flu shot so that the counties felt like they had at least been given something. So there's lots of stories I could tell you about this, lots of stories about doing studies in real life. If we have time, I will tell you that one too. But so my statistician calls me with the results. He said, I have good news and I have bad news. I said, so what's the good news? He said, well, you had a statistically significant effect. And you can see that in the first line of both tables, that my intervention arm had a statistically significant increase over the control arm in the uptake of the HPV vaccine. And I said, what's the bad news? He says, really low. And you can see it's really low. It's 3% versus 8% and 7% versus 13%. But I can tell you that virtually all of the studies I've heard over the pulpit here given, this is about the rates that we see in uptake for intervention studies for HPV vaccine when we do randomized controlled trials like this. So we had an effect, but it was extremely low. And what predicted shots? Well, if the parent was older and the parent worked. Those were the only two things that we found that predicted it. So if we go to our boxes, what predicts getting the HPV vaccine for a daughter? SES, social influences, healthcare system and families, mainly because we said, why didn't you get your daughter vaccinated? And the reasons overwhelmingly were, my doctor said she didn't need it. My doctor said she didn't need it till she started her period. My doctor said she didn't need it because she wasn't sexually active. My doctor said she could wait. All wrong, because you're in the study because you have a daughter at that age. And of course, we heard a lot about the family. The family, my mother will, if I give my daughter the vaccine, my mother will ask me why I'm giving my daughter a green light to have sex. So there was a lot of that we heard. All right, here's the test. So can we put all those boxes together and create our own multi-level model to explain cervical cancer disparities in Appalachia? Because the model I showed you, the Warnecke model, is generic. But I've been giving you little snippets all along. So everybody remember, you can all make one. This is what it looks like. So what causes cervical cancer disparities in Appalachia? We start from the top: poverty, discrimination, and healthcare system, family, social cohesion, neighborhood disadvantage, social network, social support, social influences, individual risk factors, lots of them, and then biology, genetic mechanisms, immune function, and HPV. So it is multi-level, and the levels interact with each other. And I will tell you, this is still in press. Cancer prevention research hasn't published it yet, but there's a whole summary of everything I've told you about both studies in this paper that's soon to come out. So it takes a village. This is my team over what came to be about 12 or 13 years. And the staff, both at Ohio State and then out in the community. So a lot of people say, okay, what's next? You have a Care 1, you have a Care 2, are you going to have a Care 3? Yes! So we wrote a PO1 and we had to submit it twice, but we were successful in getting a PO1. And we're in our first year, and we are going to call it Care again. We're working on what it's going to stand for, but it's going to be something like Take Care. But we're working with other areas of Appalachia, so University of Virginia, University of Kentucky, and West Virginia University. And the goal, again, is to address the burden of cervical cancer, and the way we're doing this is through a delivery of a clinic-based integrated program that focuses on tobacco smoking, Project 1, HPV infection in terms of vaccination, Project 2, and cervical cancer screening, which will be Project 3, which will also include self-testing. And, and then the last aim then is we are going to be targeting these multi-level barriers, but in the context of the clinic and the community that were related to cervical cancer. And so we'll be integrating all of these, something has never been done before, and we are going to evaluate the impact at the clinics. We're going to be in 34 federally qualified health centers, 10 health systems in 4 states. And we'll be looking at implementation, acceptability, and sustainability. And this is the model. So we have, let's see if I can get this to work again. There we go. So we have 3 projects, 4 cores, and then we have the 4 institutions, and then 10 health systems where it'll be a prevention program. But right now we're right here in this, doing our baseline collection, and then we'll randomize half the health systems to early intervention, and then the other half will be usual care, they'll just wait. And so after the early intervention, where each of the projects will be implemented in a staggered fashion, our external advisory board for the project suggested that we then test bundling. And I'm going to explain bundling to you in just a minute. And then, oh my goodness. Then bundling, okay there. And then sustainability, they'll have 2 years of sustainability. And then the late intervention clinics will start, well, we're in bundling here, et cetera. So everybody, you know, the synergy that you have to in a PO1, everybody's looking at cervical cancer, but we consider this throughout generations because we're working with kids as well as the moms. And again, we'll be using the multi-level model. And let me go through the projects really, really quickly. So the first one is called Break Free, and it's going to be looking at smoking cessation. And we'll be using smoking cessation intervention and then testing it, rolling it out. And the second one is we changed the name of the parent project to iVaccinate. We've actually pilot tested it as a implementations study. And again, we will test the effectiveness of the intervention for children aged 11 to 12 and then for catch-up 13 to 26. Project 3 is looking at cervical cancer screening, and they will be looking at HPV self-test return, as well as if you're positive, coming back for the follow-up. So this is bundling. This is my dream in my head, which is a scary place to be. But this is what I dream of doing. But in the 3rd year or after the implementation. A woman comes into a primary care office and the electronic health record alerts the provider that A, the woman is a smoker, or have you asked if she's a smoker, okay? And another alert that she needs a PAP. And oh, by the way, she has children who haven't been vaccinated, and she herself is under age 45. So if all of you know, the guidelines for HPV vaccine just increased to 45. So the provider can address all aspects of the program that we're implementing, the Take Care program, and he can introduce each intervention. We will introduce each intervention to the providers one at a time. So by the time they get to the bundling phase, we will teach them how to bundle. And the sustainability phase will carry this forward. So how does a doctor do all this? You're like, 10 minutes? How are they going to do all this? Okay, Mrs. Jones, I noticed that, you're in need of a PAP test, and I think it's really important that you get one. And when you check out, the front desk is going to give you some material about a PAP test. And I'd really like you to talk to our smoking cessation counselor. I'm going to do a referral for you that you will also get when you check out. And lastly, I haven't seen your children in for a little while. Could we set up an appointment for you to bring them in, because there's a cancer prevention vaccine that I would really like to speak more with you about, and the nurse or the front desk, whatever the clinic decides, is going to give you a little bit more information about that we can discuss at the next visit. So did that take under a minute? Something like that. Mm-hmm. So that's what we want to teach them to do. And then everybody in the office will have a role in all of those, including the scheduler, because they're going to schedule them for this, and the nurse will give all the follow-ups. So that's in my head, and we'll see how that rolls out. This is our evaluation framework from Proctor, and we will be evaluating it program, individual, contextual, and we are also going to look at cost effectiveness. So thank you very much for your attention, and that wraps up sort of what we've been doing in cervical cancer since 2002. So thank you.
start with a question. So, you know, to me, getting the young girls to be vaccinated is probably going to be the most important thing. And do you think that women are saying their doctor told me this because the doctor really said this, which is one problem, so the doctors need to be trained better to say it's paramount to get vaccinated, or are the women using that as a reason? That's question number one. But the other question is, in the study you're proposing, like the last few slides, where you're intervening at the level of the mother either needs to be vaccinated or the daughter does. I didn't see anything about trying to follow through with the intervention at the daughter level.
Yeah, so let me answer the first question. I do believe the women, that the doctor said that, because there were a lot of difficulties when we tried to implement that study, and we could not implement all of the levels of the intervention at the same clinic that the women were being seen. So, and we also have data from the study I didn't show that if a doctor recommended that the child get vaccinated, there was a significant effect in terms of the daughter getting vaccinated. So I do believe that the doctors were not saying that because the doctors don't know what to say. And that research has been proven by many other researchers besides myself.
So you may need to train the doctors.
So that's what the multi-level study is about, is that we'll be able to train the doctors in order to say, your child is here for a well-child visit today, they need 3 shots. You know, you don't say they need 2 shots and oh, by the way, there's this new one that you could consider, because that's what a lot of doctors say. So we'll teach them how to say it. And so that's sort of the focus. Now, when you get 13 to 26, we like to divide it up 13 to 17 and 18 to 26. So the 18 to 26 pitch is actually going to have to be to the person. And we are designing a whole bunch of intervention material to approach the person rather than the parent. But the 13 to 17, those are catch-up. And so we have a whole set of intervention materials say it's not too late, that you can still vaccinate.
Great.
Thank you very much. Bill. Thank you very much. Really interesting. I have questions for you. One, you didn't mention boys.
Yep.
And how much of an impact on your future studies will the effect of boys being vaccinated with Gardasil affect the parameters that you're looking at? The second question is more biologic, and that was looking at your stressors: drinking, smoking, sex, sexual activity. Have you tried to correlate that with corticosteroid levels to get a more precise measure of what stress can be?
So we are including boys now. Again, when we did CARE 2, it was not approved for boys. Now it is approved for boys. So the pilot we did of the implementation study included boys and girls. So you know, we just include that together because that is actually the UDS measure, is the proportion of 13-year-olds, boys and girls together, who have received all of their shots. So that's the measure we will be using. So no, we did not collect corticosteroids because it required very intricate collection, which we can't do out in the field. I will tell you that some of the clinics did not have the -80-degree freezers. We had to buy freezers for a lot of these clinics just to put our blood specimens in. And some of the counties we were in, FedEx or UPS did not even deliver. So my team developed a Pony Express system. We actually bought the freezer that you can put in your cigarette lighter or whatever in your car, and we would transport the specimens ourselves. So it's not, you know, I know all the great work that's been done here in Chicago, but we could not collect the specimens in that manner. We did look at reactivation of latent EBV as kind of a marker of the immune system, and I don't have the slides to talk about that today, but it was interesting too. Yeah. Oh, Kat.
Right, so a couple of questions. One, sort of on the basic science side, I saw that in one of your slides, I think only about a third of the sample that you were looking at were 16, 19, 6, 11, and then about 2/3 were other high risk. But when you were looking at the mutations, right, for smokers and non-smokers, you were saying for this one, non-smokers, you know, it increases. For versus whatever, right? And I wonder if anybody has looked at it, or anybody in the room that might know this, whether those mutations, right, may be, I guess, differentially promoted based on the subtype, HPV subtype, right? Such that if you have infection with these subtypes, then these are the mutations that perhaps are most prevalent in that cancer, whereas if you have infection with those subtypes, these are the other mutations. And or, is there a need for co-infection? You know, we know that in our population, the subtype co-infection is perhaps different just with prevalence. That's one. Then the other question is more at the population level. So we know that there's like this documented like shortage, you know, that is going to continue to increase in terms of the needed services for like OB-GYN, such as for PAPs, versus the professionals who conduct those services. And I'm just wondering if you have it in your plans, or if you've given it some thought to how you may, I guess, increase capacity in those facilities already, so that you don't just tell them, hey, I want you to schedule this, I want you to schedule that, because you and I know that some of it is that they won't come back.
Yeah, so that's what we're going to work with the clinics about, assuring follow-up, and teach them how to do that. We're doing that now in some other clinics, federally qualified health centers in Appalachia for colon, to teach them how to follow up on abnormal fits, which they hadn't been doing. So we're doing the same thing here. We're also going to teach them how to bill for smoking cessation, because you can bill for it.
Yeah.
You know, I mean, you might not get a whole lot of money, but you can bill for it. So we're going to teach them how to do that. A lot of this is not that they're terrible doctors. It's that nobody's taught them how to do this. And so that's what we're trying to do. So your first question, you have to remember that those are different samples from different projects. So in the case control study that looked at the genotyping, we didn't collect HPV from the cervical cancer cases. We didn't type them because it's 100% positive for HPV. So we did not collect and type HPV for the cervical cancer cases. So yeah, good idea, but we didn't do that. Yeah, go ahead.
Can you hear me? Okay.
Yeah.
There's a few part of the question is, how do you, for Care 1 and Care 2, how did you address the uninsured and underinsured in that population? And also, I believe most of them, they don't usually go to get preventative services. And how do you outreach to them and convince them to go get the preventative services? And as far as for the Care 3, what is your plan to get insurance to cover the HPV vaccine for the adults, the 27 and up population?
Okay, so 27 and up, that's not going to be a major focus of Care 3. We are going to be doing qualitative work to find out what people think about the recommendation up to age 45, because there's nothing in the literature right now about what people think of vaccinating women or men 27 to 45. There's nothing in the literature. If somebody knows any qualitative work, let me know, because there's nothing. And there's nothing in Appalachia. So before we can even teach the docs about vaccinating that age group, we have to understand it. And the recommendation actually is shared decision making. So what does shared decision making mean?
That's what I'm saying.
Nobody knows what that is. So that's what we're doing, a lot of qualitative work. And our focus groups are going to start once we get our RB approval. That was submitted December 20th. And anyway, don't get me started on the IRB. Okay. That we will be doing focus groups, and we're going to be collecting what providers and what parents think about the increasing. So that's the 27 to 45. I can tell you anecdotally that people are saying that insurances are coming aboard one after another for that. So your second was, so the Care 1 was all done in clinics, so they had access to care. And also we have the Affordable Care Act. We had Medicaid expansion in Ohio when that came about, so that really helped. So we have ways that we can get people qualified for BSAP program, breast cervical cancer early detection program, to get PAPs and et cetera. And in CARE 2, it was not a problem. We actually did the PAPs. In Project 3, the psychoneuroimmunology model, we did the PAPs. So they got free PAPs at baseline and 1 year and free HPV vaccine. So for Project 3 was all free. Cost is really not becoming an issue now, especially with the Affordable Care Act, at least in our clinics. Yeah.
So your multi-level intervention, and you identified social cohesion, discrimination, and poverty are like sort of social neighborhood level vectors. Have you like started thinking about what sort of like neighborhood social level interventions that could actually address those issues?
Yeah, and we're doing key informant interviews also in addition to our focus group, so we'll be able to get sort of a feel of what the community level is. So some of the things we found is, as I told you about cervical cancer and cervix and cancer, you don't like to talk about it. We talked to clergy about the HPV vaccine. So there's a lot of these social norms. Those are mostly what impact. The social cohesion is a little harder to deal with, things like that, but we're also going to get a whole list of resources. So if somebody needs resources in their community, we'll know where to send them. So it's really facilitating, letting people know where they can go for help. That will increase the community resources. So I want to tell you one story before we ended, and that was about discrimination and about people and Appalachian self-identity. So we did another study with 5 Appalachian states, and it was diet and exercise. We ran it to churches because church is really important in the community. And we modeled it after Princeton Living Well. So we did some focus groups with Appalachian, Ohio residents from a church, and we wanted to call it Appalachian Living Well. And they said, oh, this is wonderful, it's great, yada, yada. So then we did a focus group in Appalachian, Pennsylvania. And we said, we're gonna call it Appalachian Living Well. I said, we're not Appalachian. Yes, you are. No, we're not Appalachian. Those people, okay, are you ready? Those people live in West Virginia and Kentucky. They are poor, they work in the coal mines, and they have no teeth. And so that's why, I was telling you that there is no Appalachian self-identity. That at least in our state, people, and the reason we care the way it is people relate to the state of Ohio. They're very loyal to the state of Ohio. And the mountains, libraries, their family, and schools, very important to them. Education is very, very important. So you have to know the context of where you're working, and you have to know the population if you're going to make an impact. So thank you all for your attention. Sure.
Great.
Sure. Let's see. Can you take the tape off my back?
Yes, I will. Good.
Perfect.
How about intervening at schools, middle schools, and is that a dicey proposition? But
Dicey.
boy, if you can get
Dicey.
social